Hailing from Jamaica, Queens herself, Dr. Dara is the first medical practice in New York City to treat patients with medical cannabis. She is double board certified in nephrology and internal medicine. She earned her combined BA/MD degrees from Brown University, Brown Medical School, in addition to completing her master's in medical science at Brown. As the first and foremost expert in the use of medical cannabis treatment in New York City, Dr. Huang educates physicians and teaches the general community about the science and research of cannabis for integrative therapeutic healing and medical care. We're so excited and honored to have you, Dr. Huang.
Thank you so much. Thank you for the invitation. I put the slides together for the OBGYN department very specifically, so I think you'll gain a lot out of this. I was raised in Jamaica States myself, so not so far away, and I'm very familiar with the area, so this is close to home for me. These are some images that you might have seen. This was broad daylight on Broadway in Soho. Cannabis is not something that's behind closed doors. It's not enforced as far as the legality of it. I'll go into what the current status is now. Again, another image near Canal Street. These images, while used as a quick quip, are serious implications as far as health goes. This has become much more mainstream. It's important as physicians to know what patients population may be considered adult use, recreational, for fun, or for medicinal use. That Time magazine, there's a couple of them that happened at the same time. This is when New York was qualified. That image that we have where marijuana goes mainstream, this was from 2017. We were sort of first in class in terms of getting that information, good, accurate, credible information out there. It's now become a big business targeting specifically to the wellness population. If you look at the packaging, marketing, it's very appealing and what is considered recreational on the street per se versus what you might find in a supplement store. You have to be very careful as far as the quality and the product itself. Over-the-counter medications, a lot of labeling that may be misleading. When we talk about cannabis, when we talk about marijuana, we talk about CBD, that I'll try to elucidate. So the big question is, what is a nephrologist doing speaking at an OBGYN grand rounds, right? After all, if I were to present to you a 34-year-old woman with hypertension and 2+ proteinuria, then what would a nephrologist do? And the treatment, well, you're too fast. The treatment would be an ACE inhibitor, an ARB, and the OBGYN's next step would be obviously to deliver the baby. And the differences in how we view anatomy for you would be looking at the anatomy and looking at the relationship with the kidneys and making sure you don't clip the ureters. But for me, I'm just interested in the ins and outs and what the creatinine is. But I do have strong ties to the OBGYN world. This is my Jamaican auntie, Dr. Martin, and my father, who's in the center, is an OBGYN and gyn-onc. Lucky for him, he had 4 daughters. We all became physicians, gyn-onc, OB-gyn, and colorectal surgery. And here I am. I'm the black sheep of the family, being a non-surgeon. Let's go back to what cannabis is and how that all ties in. The learning objective is to discuss the clinical applications of medical use cannabis in our patient population. We'll discuss the science behind the human endocannabinoid system, what the rules and regulations are in New York State, and discuss very specifically the ACOG recommendations on the use of cannabis in pregnancy. As a background, cannabis is used widely throughout the world. 200 million people have used cannabis in 2007. Over 20 million Americans almost daily. This is not something that is uncommon, whether they report it or not. From Your Society's Green Journal in 2021, from Canada, this is a retrospective analysis comparing current users versus non-users for moderate to severe pelvic pain before legalization, which is in 2018, tended to be younger, have lower educational levels, lower income, and more frequent use of pain medications, including opioids. Post-legalization, there was more cannabis use. The population had higher levels of education. They were using less NSAIDs and other pain medications and more herbal medications. This is just a very recent study looking at the use of cannabis recreationally. The landscape in the US has changed dramatically over the last 6 years. In 2016, 29 states were approved for medical cannabis. 8 of those were for adult use. New York was the 23rd state. It approved in 2014 with the first dispensaries in 2016. This is 6 years later. This is past February. Now you have 37 states that are approved for medical cannabis and an additional 10 states for adult or recreational use. New York was approved last year. The first dispensaries for adult or recreational use still has not come up yet. That's still in the works. Things are changing very actively. And of course, as far as the shifting landscape, there are a lot of reasons for this. But one main advantage or use is the fact that the opioid epidemic is of huge concern that have included deaths in the US and worldwide. Safety of cannabis is something to take a look at too, not only in harm reduction, but with medical cannabis laws. And this was an original article in JAMA that there was a lower rate of overdose mortality. Cannabis is far less dangerous as a recreational drug compared to tobacco and alcohol. The lifetime dependence of cannabis by itself is much less than even tobacco and alcohol. And I'll explain the reasons in upcoming slides. From the American Journal of Public Health, looking at recreational cannabis legalization in Colorado, with the passage of medical cannabis laws, patients were taking objectively lower doses of opioids. It's not only just for harm reduction, for pain control, but also showing the benefits. As of now, the federal law still recognizes cannabis as a regulated controlled substance in category of 1, which means that it has no medical benefit, whereas, say, for example, cocaine is in 2. The other substances in the Controlled Substances Act, Schedule 1 is LSD and heroin, for example. Cannabis has medicinal benefits as well. Multiple studies specifically for cancer, chronic pain, and multiple sclerosis. Cannabis can be used at multiple levels of pain reduction. So not only towards the end when people are at the point of taking opioids and it's refractory to opioids, but even earlier stages. As a nephrologist, NSAIDs is our mortal enemy. So in some ways, as an adjunct or a complement, it could be considered much earlier and safer too. Another article that was pulled from Green Journal, this was looking at medical cannabis for gynecologic pain conditions. This was a systematic review where survey data was pulled from randomized controlled studies, cohort studies, cross-sectional studies across the databases. It looked at the use of cannabis treatment for different pain symptoms, specifically for chronic pelvic pain, vulvodynia, endometriosis. The prevalence of cannabis use was from 13 to 27%. This was a very wide range of route of administration. So whether it was ingested or inhaled, that wasn't considered as it was specifically for pain and gynecologic issues. Many people use cannabis multiple times a week, and the dosages ranged from 20 milligrams of THC and 2,000 milligrams of CBD, which I'll explain in a second. Significant pain relief across the board, including the 6 prospective cohort studies. And in summary, it showed that data across the board improved a number of GYN conditions. This is also reflected in the New York State program. This is one of the pull-down lists it can be qualified for, and opioids alternative for pain is one of the conditions. More specifically for gynecologic health, menstrual cramps, endometriosis, post-surgical pain, osteoporosis, these are all listed. Fibromyalgia, the treatment that people often use this for, despite the diagnosis, the symptoms are shared. So pain relief, sleep, relaxation to help with nausea. This is through New York State. If you recommend a patient for medical cannabis, it does come up on the physician's monitoring prescription program, where people have had previous controlled substance use, but also specifically the medical cannabis that is here. With pharmaceutical opioids, there's a number of deaths. Cannabis, there hasn't been any deaths in 5,000 years. The science behind cannabis. So why does it all work? How does it work? So what is cannabis? It's plant, right? So it's a flowering plant. There's a number of varieties, sativas, indicas. It's composed of numerous chemical compounds. The 2 major ones are called THC and CBD, so delta-9 tetrahydrocannabinol and cannabidiol. Depending on the processing of the major cannabinoids, whether you are consuming it raw, whether it's heated, whether it's aged, it does confer different medical benefits. And how it works is this. THC and CBD are the chemical components that's found in the plant itself. So that's the THC, the CBD. There's other minor cannabinoids too, including CBC and CBN, CBGs. And those are the plant-derived phytocannabinoids, plant cannabinoids. They all go down to the same endocannabinoid receptors that we have within our brains and nervous system, but throughout all the organs too. I had the pleasure of meeting Dr. Mushulam, who described all of this and the entire system. So not unlike the gastrointestinal system, the pulmonary system, we have an entire endocannabinoid system within our bodies. And what we have are called endocannabinoids. So not THC and CBD, which is the plant form, but we ourselves make our own form of endocannabinoids naturally. So it's even found in mother's breast milk. So there's anandamide, which was coined by Dr. Mushulam. There's also 2-AG, which isn't written here, but they all go down the same brain receptors that we have naturally. The three main components of the endocannabinoid systems are the endocannabinoids, which is anandamide, as a word that was borrowed from the Hindi dictionary that means pure joy, bliss. There's also 2-AG, the receptors itself, which we have in our own bodies, which is why we're receptive to these plants, which is CB1 and CB2, and then the regulatory enzymes that facilitate the process. So why do we have the system at all? Why are we responsive to it? This quote I like from Professor Vincenzo Di Marzo. In a nutshell, it's to relax, eat, sleep, forget, and protect. Why is this important? I mean, if we say go through Times Square, stimulation coming to us at all times, we don't want to remember all of that. We want to be able to see that and then forget it, put it away, and have it not necessarily be continuing in our memories. This is another depiction of the human endocannabinoid system, as I mentioned. The plant form locks and keys into our receptors, and the receptors are found throughout the body, going through the same receptor. So just another look at the summary. So the power of cannabinoids. So why that works, why the THC CBD has psychoactive effects or non-inflammatory effects or pain control effects is various, because we have the receptors throughout our entire body, just as we would be responsive with our natural endocannabinoids. The distribution of CB1 receptors, mostly in the brain, but throughout the nervous system, throughout the bodies, and depending on which phytocannabinoids, which element it is, the THC is psychoactive, the CBD is not. This is an interesting slide. So this is why you may overdose with opioids, and with cannabis you cannot. There's an area in the brainstem called the pre-Bot-Zinger complex. This is where the mu receptors are located, which can cause respiratory depression. There's a high density of the opioid receptors in that area. However, with cannabinoid receptors, there's a paucity, and so that doesn't exist there, which is why you can take tons of cannabis and not overdose with it. You would feel a lot of other things. You may feel sleepy, you might feel psychoactive, but you won't overdose. This is the pharmacology that the THC is passed through the cytochrome P450 system in the liver, and it can be passed through the maternal breast milk as well. There's multiple interactions with cannabinoids, so as physicians, you would be aware of the interactions. It could either be an inducer or inhibitor or even a substrate, depending on what medications. Specifically, I look at obviously Coumadin, but there's a whole host of medications you have to be aware of. Cannabis is to be added, not necessarily to discontinue them, but to be aware of it and to monitor their levels more closely. Other interactions, anti-seizure medications, antifungal medications. So the major cannabinoids are THC, but I had mentioned that there are also minor cannabinoids, CBC, CBG, there's terpenes, flavonoids, so there's a whole number of parts of the plant. So if you take an orange, the vital vitamin that we pay attention to is vitamin C. You can certainly get that from a supplement, but eating the orange itself will treat scurvy. All of these plant components, and this is why we talk about whole plant extracts rather than isolates, is because there's something called the entourage effect. The cannabinoids, THC, CBD, they work synergistically together, including all the minor cannabinoids, including all the fatty acid amides. So these are all the entourage effects. So again, you can take vitamin C to treat scurvy, but you can probably just eat an orange and have the same effect as far as the benefit and also without any overdosing. And again, just to be complete, the synthetic cannabinoids, Marinol, is FDA approved, but this is a synthesized THC. And those who take it, it's used obviously for stimulating your appetite for those who have cancer or anorexia, is number one, people don't feel well when they take it. They feel high, and sometimes it just simply doesn't work. Synthetic illicit drugs would fall in the same category of something that is not natural. This is specifically made with an intent to hone in on one of the components of the entire plant. Let me just briefly go into what we have in New York State. It was called the New York State Medical Marijuana Program, but with the addition of adult use program in this past year, and it's now been changed to the Office of Cannabis Management. The nomenclature is also important as far as implications of what the word marijuana is compared to cannabis, which is the appropriate term. This is what a dispensary may look like. Very clinical. They have pharmacists at each dispensary. There are different products, tinctures and sprays, pills, capsules, vapor form. The forms at this time is all regulated through New York State. Very high levels of regulation. There's liquid form of oils, which is taken under the tongue, taken sublingually. Vapor form, like this is not smoked and this is not heated with fire. It's heated to a regulated temperature for sustained heat component, much like for those purposes. An asthma pump or something that is inhaled. And the process is this. The patient would be coming to a prescriber such as myself to certify them appropriately. They would get a certification number. For them to register online, they must be a New York State resident or have a driver's license or have some kind of address. These are within state laws. They would receive a card, a temporary card initially, and then the hard card. And then they would then be able to purchase at the approved registered organizations or medical dispensaries. There's a very specific list. So this is not something that you can just walk in and purchase. There's a process for these products. The approved forms are oral, sublingual, topicals, and non-smokable vapor. They have now added pressed powder in flower form, trying to be on level with the adult use as far as what your patients might be coming in and what they may be taking. It would be upon us to separate out what it is that they're getting in a vitamin store or online versus what is at a dispensary, whether it's a medical dispensary or a store that might be coming up and selling products. There's a lot of telemedicine services now. I myself have done telemedicine before it became cool in 2020. So very familiar, comfortable with that. Now the dispensaries are also online with the delivery, and that was really prompted in the past 2 years. We talked about all of the things where cannabis can be used for pelvic pain and for pain syndromes, but what about pregnancy? Those who are self-reporting cannabis use in pregnancy, it's increased over the last several years, up to 30% of those in young urban populations. People still continue to use it. It's suggesting that people are not aware that cannabis can be just as dangerous as tobacco, specifically in pregnancy. It's seen as something that is recreational and it's continued to be used throughout pregnancy. But is it safe to use? As far as the research goes, it's still in the early phases of investigation. Early reports show that cannabis exposure can disrupt normal brain behavior in the fetal development. Babies might have lower birth rate and increased risk of stillbirth. And it's unclear whether it's because it's cannabis itself or whether it's because it's often taken with cigarettes or alcohol. So that might be a confounding factor, which has to be teased out. It does seem to overall increase the risk of preterm birth. Taken from ACOG. So there is a lot of attention for messaging with cannabis and pregnancy as far as the effects on the fetus as well as for the mother. Cannabinoids can reach the fetus crossing the placenta. Very limited research at this time. More information is going to be coming out as time goes on. ACOG, in summary, recommends that pregnant women do not use cannabis. Is it safe to use while breastfeeding? Insufficient data as far as breastfeeding goes. There is transfer of the cannabinoids into the breast milk. ACOG and the American Association of Pediatrics recommend that cannabis not be used during lactation. This is the committee opinion on that. The next slide I'll show you more specifically. Written in 2017 and then reaffirmed in 2021 for and during pregnancy, that they should be asked about their tobacco and alcohol use, but also include cannabis in that conversation. Women should be counseled about concerns of using cannabis during pregnancy. They should be encouraged to stop. There's insufficient data on infants during breastfeeding, but the safest thing for now is to discontinue. There are those who are not using it for recreational purposes, but also for medical purposes. For example, one of the things that cannabis may be used for to treat morning sickness or hyperemesis. There is no evidence at this time that it's helpful in managing nausea and vomiting of pregnancy. As you know, the recommendation is behavioral changes with diet and lifestyle changes. The FDA approved is diplegious, but you can certainly also just recommend Unisom and vitamin B6. It's important to note that even though the woman may be pregnant and vomiting, doesn't necessarily mean that it's hyperemesis gravidarum. You want to also ask, does she have a history of active cannabis use? The differential here is cannabinoid hyperemesis syndrome in pregnancy. So whether you're pregnant or not, you can still have cannabinoid hyperemesis syndrome. This is with high regular use. Patients report when they go to the ER that they take hot showers to help relief. They're given fluids because their volume depleted. But the treatment for this is simply to discontinue the cannabis, and that would resolve the issue. So what else to discuss with your OB patient? To screen for substance use, to inform and counsel, and not to penalize. What about cannabis and fertility? It has not been shown to significantly affect fertility at this time. There's a couple of prospective and retrospective observational studies. Again, the literature is limited here. At least in these studies, it has not significantly affected fertility. The months to conception for women, a year and a half, and for men, it's 6 to 12 months. Benefits for medical cannabis: it's generally well tolerated, and there are few serious side effects because it's a natural plant that doesn't have the receptors in the specific areas that causes respiratory depressions as you would opioid, commonly used for pelvic pain, for gynecologic symptoms. Whether patients are reporting it or not, they are looking for other alternatives. We discussed the science behind the endocannabinoid system, including the endocannabinoids receptors, as far as what the New York State Office of Cannabis Management regulated specifically for New York State, but the FDA doesn't regulate or evaluate cannabis, so that's on the federal level. NKCOG recommends that women stop cannabis use, whether it's medical or for recreational use. So there's much more to learn, a lot of data to be garnered. Cannabis use is become mainstream, and to be aware of what the potential consequences on our patient population. Patients will be coming to you. If you don't bring it up, they may not either. A lot of references that I have available, but for me, I don't use cannabis myself, but dear to my heart, my sister passed away from metastatic colon cancer, and she didn't have the opportunity to use this. I think it would have been helpful for her. I'm sort of channeling the OBGYN and delivering information that I think would have been helpful. And I thank you for your attention.
Thank you.
All right.
That was so insightful. How do you counsel your patients about the psychotropic effects of cannabis? Can the use of cannabis trigger schizophrenia?
It's THC side of things that are psychoactive. The CBD and many of the other components is non-psychoactive. So to be aware of what the patient is actually taking in terms of what the product is, and also making sure that the labeling is correct. The THC is what has the psychoactive effect. It causes that high that people may be looking for, but it's also quite elegant plant. It's almost bimodal. You can temper the amount of psychoactivity with the CBD. So the THC is an active component. CBD is what's called a negative allosteric modulator, and so it reverses itself in a sense. Patients who are at risk for psychoactivity, the major contraindication in terms of patients would be those who with psychosis. So bipolar disease, specifically if they have mania, schizophrenia, that information is still being looked at. There are other cases where it is effectively used for mental illness, and specifically those who have a history of psychosis. You have to be very careful not to exacerbate something with a baseline. So whenever I see a patient, say, for example, with PTSD, I make sure they are also working with a psychiatrist with bipolar disease. The idea with all the medications is to go low and slow. I would err on the CBD side of things and be very careful in looking at all the medications and just monitoring regularly.
For me is that I've seen patients come in who have known cannabis use but don't necessarily speak about it, and then become pregnant and think maybe it's okay, maybe it's not. Just having an idea of how it works and awareness of it, I think, is important.
I agree. I mean, whether you are one to recommend or not, that's not the point of this. It's really to know that what are people are ingesting, what are they taking, safer, what is not safe, what the ACOG recommendations are. We haven't put out the recommendations for chronic pain. There was very few studies that were available. If you have any residents or fellows who are interested in doing any kind of research, I mean, it would be portable. It's more knowing what people are taking, what's affecting their body, and they're getting their information not necessarily from their physicians. And I think that that's it's important for us to at least have an awareness so that we have a clue of what the next steps may be or further investigation.
I was just going to add, you're asking about patient encounters. We had a patient in clinic recently who was using cannabis for hyperemesis. She swore that was the only thing that helped her tolerate food.
Yeah. So that's why I specifically wanted to mention that, because in that case it is used for medical purposes. I think the ACOG recommendation would be to find other alternatives, which I'm sure you've tried, and you have to also consider, the cost risk benefit. I mean, are they going to be so volume depleted that they're going to be going to the hospital for fluids, or is this something that is minimal amounts, and if they can't keep anything down, I think that's going to be a judgment call. And I think that that's where we come in terms of what is allowable, what's not, what's too much, what's not, what's dangerous for mom and baby altogether. Is it cannabis? Absolutely not. Or is it going to be like, well, let's take it step by step and see each patient individually and see what the situation surrounding that is. But I think that's for medicine altogether. We're making those decisions all the time, right?
Thank you so much.
All right. If you have any questions, then you have my contact information. I'm happy to answer or help out in any way possible. But thank you for allowing me to speak this morning. Thank you.